I'm Caroline Childs, and David Nager and I are directing the resident boot camp again. We're very excited about this year's program. This is our 5th annual resident boot camp, and we've just been very excited about the response. So we've got a great program for you this morning, but before we launch into the program, David is going to go over some of the details about how the day is going to unfold.
All right, good morning, everyone. Your second welcome. We're excited you're here. This boot camp was an amazing idea that actually Caroline came up with right before the first one, and it's been a hit ever since. So thank you all for being here. I have announcements, and we're starting with the single most important thing, which is the bathrooms. So they are outside. If you go to the registration desk and keep going, that's the bathrooms. Second most important is the internet. It's actually on the front of your booklet. So inside those plastic folders, there's a blue circle, and then the address starts with 2023 STR, and the password's right below it. Okay. So today it's a really exciting program for you. We have 2 sessions in the morning, and Caroline's going to introduce each one. Between the second and third is a lunch. It's a free lunch. It is sponsored, but we have a fantastic speaker who will also be giving some great information during it. We are all invited. It's over in this area, and we'll announce more closer to that. But plan for lunch with us. Our program here wraps up at 2:15, but then the rest of the STR meeting occurs. So most of you are registered for the full meeting and boot camp. But even if you're just registered for boot camp, you are welcome to the program today. So we have 2 in the afternoon. One is fundamentals of interstitial lung disease. So that's a perfect intro, especially if you're in training. And then there's right before the welcome reception, we have 2 options. One on AI, which is very topical, and one on remote education, which is also very topical. And then the day ends with a welcome reception. Everybody is invited. It's in that sort of round courtyard on the first floor towards the front of the hotel, but that might be the opposite side where you entered in. And that's at 6:15. Food, drink, everybody is welcome. And then the last things I'll say before we go to our first speaker is if you have not yet, please join the STR. It is free for trainees. It's something the board was very intentional to create. So all you have to do is sign up. And then second is we realize there's so many residents and fellows interested in being involved in our committees and the work of the STR, but we didn't have a way to sign up, so we now do. If you are interested in being involved, we have a sign-up sheet at the front desk, so right out there, over in this direction, and then you can express interest. If you have no specific interest, just say anything, and we might reach out to you and see if you want to be involved in some of our committees. So thank you all for being here, and we'll learn about our first speaker.
So our first session this morning is lung cancer, and probably, to me, like the most important thing I do as a cardiothoracic radiologist is help detect, diagnose, stage, monitor treatment of patients with lung cancer. So we're going to start with screening this morning. Our first speaker is a leader in the field of lung cancer screening. This is Dr. Debra Dyer from Denver, Colorado, who will talk to us about lung cancer screening. And she's doing it on a very special day. This is her birthday, so happy birthday.
Yes, cake for all later somewhere. Okay, well, good morning. It's nice to see everybody here, and it's definitely early for some of those folks from the western part of the United States, but good to have you all here. Oops. All right, I'm already failing at the... Okay, these are my disclosures, none of which affect my presentation today. And so we will be talking about some background and rationale for screening, describe the current status, review the latest recommendations from the U.S. Preventive Services Task Force and Medicare, describe some of the necessary components of lung cancer screening, review Lung-RADS, and discuss barriers. So most of you probably know lung cancer is the leading cause of cancer death in the United States. There are about 14 million people who are currently eligible for lung cancer screening. Survival is related to the stage at diagnosis. Chest X-ray screening is not beneficial, and only about 5.8% of eligible people in the United States are getting screened. So what the message there is there is ample opportunity for all of us, any of us, to get involved and promote lung cancer screening. And very importantly is with screening that about 60 to 80% of non-small cell lung cancers can be identified at stage 1, therefore curable. So we're looking for cancers in the early stage as opposed to the later stage as shown on the right. And of course, the world of lung cancer screening really got off the ground. I mean, it has been certainly around for a long time thanks to the LCAP group, but with the publication of the National Lung Screening Trial, we had evidence that lung cancer screening can make a huge difference in mortality. And in fact, with lung cancer screening, the NLST found that using CT for screening that we could reduce mortality by 20%. And then the Dutch-Belgium Nelson trial publication came out, which really validated as well the findings of the NLST and even showed a better mortality benefit, and especially among women. So what we have now in the U.S., fortunately, is a recommendation from the U.S. Preventive Services Task Force that patients be screened, and it's with a grade B recommendation, so it is good evidence. And just in the past couple years, they did drop the starting age to 50 and recommended screening up through age 80 in patients who have at least a 20-pack year history of smoking. Now, the 2021 recommendations kept in place that upper age limit of 80, so that sometimes can be a problem, which we can talk about maybe later among questions. And also, they kept in place the 15 years since quit. Those of us that were working, trying to get the task force and then subsequently Medicare to adjust these in their recommendations, unfortunately, we were not able to get them to eliminate these. So those are unfortunate sort of limitations, that upper age limit and the 15 years since quit. Other recommendations from the task force were to continue to screen on an annual basis, and of course, annual screening is the key to the success of lung cancer screening. And they also recommended that shared decision-making be performed. The task force didn't say that it would be required for reimbursement, but Medicare did say that. And certainly the task force recommended structured reporting, such as Lung-RADS. So, as I mentioned, Medicare, they also updated their eligibility recommendations, and they dropped the age to 50 as well, but they have an upper age limit of 77. So, of course, that's different than the task force, which can cause a little confusion. The starting pack years is at least 20 pack years, and then 15 years since quit. No signs or symptoms of lung cancer, and your program can decide more or less what you think those are. In my program, we use hemoptysis and unexplained weight loss. And then there does have to be an order for a low-dose CT. Now, the other thing that Medicare kept in place, which is important to recognize as far as structuring a program, is that patients must go through a shared decision-making visit before their first low-dose CT. So some programs which are designed to be a centralized program actually will have typically advanced practice providers, nurse practitioners, or PAs that work within the program to provide the shared decision-making. If the lung cancer screening program isn't centralized, then it is a requirement that the referring provider provide some documentation of this shared decision-making visit. And during the shared decision-making visit, the expectation is that the patient hears about the risks and benefits. Some sort of decision aid has to be utilized. It's very important that the patient understand that annual screening is the expectation, and that patients who are currently smoking do need to receive some sort of information, resources, or counseling about smoking cessation. Now, as far as the imaging facility, one of the things that is required is that the imaging facility, and that means the radiologist, needs to use some sort of structured reporting. And of course, Lung-RADS was developed initially for this purpose and is recommended as a guide for doing structured reporting in lung cancer screening. The Medicare NCD actually, though, did do something pretty significant with the last update, and that was to eliminate the requirement for reporting data to a CMS-approved registry. And so the American College of Radiology had the only registry available. It is still recommended that programs report data to the registry because it is our only registry that really collects quality data on lung cancer screening. So in summary, the eligibility requirements are that patients be ages 50 to 80 for commercial and some Medicaid programs, ages 50 to 77 for Medicare. Patients have to have at least a 20-pack year history of smoking. And if they're currently smoking, they're eligible, or if they have quit, they have to have quit within the last 15 years. And then, as I mentioned, no signs or symptoms of lung cancer. And then, importantly, a willingness and ability to undergo diagnosis and treatment. They don't have to be a surgical candidate, but the expectation would be they would at least get radiation therapy or some other ablation therapy. Now, for insurance coverage, pre-auth is required in some situations. Most commercial plans require pre-auth. Some Medicare Advantage plans do. And the pre-authorization can be a little bit of a problem, because what you will find out when you get involved in lung cancer screening is sometimes you know a lot more about it than those folks that are on the insurance side approving or disapproving screening for a patient. So it does help to be really informed about this. No pre-authorization is required for traditional Medicare. And in your state, Medicaid will vary. I'm happy to say in Colorado, we do not have a requirement for pre-auth for our Medicaid patients. But importantly, we need to realize that with that grade B recommendation from the U.S. Preventive Services Task Force, lung cancer screening is provided to patients with no copay or cost sharing. Now, that's the initial screening exam. That's not any follow-up exams that they would need for workup of a nodule. But the initial screening is required with no cost sharing for the patient. And one of the things the American College of Radiology has done is put together a nice resource that summarizes some of these economic and billing issues. And I would recommend that if you are interested, and I hope you're willing to help develop lung cancer screening programs or get involved in the program where you are, that you can use this as a resource. Now, when we think about lung cancer screening programs, there really are some basic components that are there in programs that are successful. And one of the things right off the bat we need to realize is that there is an infrastructure that is needed for screening. And if you just think about mammography programs, breast screening programs, they all have infrastructures as well. So you can't just do a CT, and that's going to be my overwhelming message today, that lung cancer screening is not just a CT, it's a program. And so first of all, you have to have somebody who's looking at eligibility. And this is really pre-screening for screening, if you will. The shared decision-making is important, and in fact, it has been shown to be so important that many programs require it every year for every patient, regardless of whether they're Medicare, because it is an important touch point for patients. Certainly, patients who are currently smoking need to be offered smoking cessation resources. Technologists need to know how to do low-dose CT. I think most of our techs now are pretty good at this because they're doing reduced-dose CT on a lot of patients. Radiologists do need to be trained in Lung-RADS and have experience with lung nodule management. These programs need some sort of infrastructure for tracking patients and reminding them to come back. And then a multidisciplinary committee for review of suspicious nodules is incredibly valuable. And if your program or your facility doesn't have that, then first of all, I'd say see if you could start one. But if you don't have the ability to do that, you at least need a referral process for referring patients for care escalation. And so, as I said, it's not just a program. It's not just a CT, it's a program, and also it requires a team. And some of the team members that can be really, really valuable in this effort is to have a program coordinator or navigator to help with that infrastructure and work with patients and make sure they're eligible and really get patients back in for follow-up exams and so forth. Also having nurses or advanced practice providers that can help manage some of the follow-up recommendations and sometimes do the shared decision-making. Many of the advanced practice providers may be tobacco treatment specialists that can help patients with smoking cessation counseling. And then obviously a very important person to have involved in the process is the primary care provider. At least have a person who's a point person in the primary care community or part of your facility who can help be an advocate and champion. And then, of course, radiologists, interventional radiologists, pulmonologists, interventional pulmonologists, medical oncologists, thoracic surgeons, radiation oncologists, and so forth. This is actually, all these people can contribute to having a successful program. I mentioned Lung-RADS. Importantly, I won't delve into details here, but there was an updated version of Lung-RADS released in November, so it's called Lung-RADS 2022, and I would certainly recommend that you look at that because it continues to be improved. And we look at now, like we're including evaluation of cystic nodules, which weren't previously addressed. And this is what it looks like. So, of course, we have the Lung-RADS categories of 0 through 4X. So the ones that are considered negative are Lung-RADS 1 and 2, and the specifications and features of the nodules are shown here. And then Lung-RADS 3, probably benign, but the recommendation is for a 6-month follow-up. Lung-RADS 4 are the positive screens, and most programs will have those Lung-RADS 4 cases reviewed in a multidisciplinary committee or, as I said, some sort of referral process to a nodule clinic. And the 4A are the suspicious nodules, typically needing a 3-month follow-up, where the 4B and the 4X nodules are the most concerning, and these would typically be recommended then either for biopsy or at least PET. And so here's an example of just how Lung-RADS works. And so you can see on the left there's this part solid nodule, and it is suspicious looking. Some folks might say, well, it could be infection or it could be some focal inflammatory lesion, so we're going to recommend a 3-month follow-up. But sure enough, so this patient comes back at 3 months, and now you can see that that part solid nodule is nearly all solid. The margins are irregular, and so now this is the 4X lesion. This is the radiologist saying, I think this is cancer. We really need to work this up now. And then the S code is any actionable finding outside of a lung nodule that you're seeing on the lung cancer screening CT. And these include like coronary artery calcification, aortic aneurysm, interstitial lung disease, and so forth. And coronary artery calcification is the most common incidental finding we see, and it is important to make sure that those patients, particularly with the moderate or severe or heavy calcification, get further follow-up, at least some sort of advanced risk assessment, and their primary care provider needs to attend to that and see if maybe the patient can benefit from some intervention. Now, the American College of Radiology did develop an incidental findings guide, and it does go into detail about how to manage many of these more common incidental findings that we can see on lung cancer screening. And then just briefly, I just want to mention again that the care continuum is very important in lung cancer screening. There needs to be somebody that can help be sure that patients are getting the follow-up they need. Now, just a little bit about barriers. We know there are complex eligibility requirements, the pre-auth, and so forth. Those are things that really can make lung cancer screening more challenging. And we also know that we've got some work to do to educate patients and providers. And then we also know that our primary care providers, who are the primary sources of referrals, are overburdened. And so we're trying to figure out ways to make lung cancer screening referral easier. And so the other thing I'll mention is that I think it is important, if you have a program or if you're starting a program, be sure you have knowledge of your statistics, and you can be able to explain to referring providers and, importantly, to patients really what the expectations are from a lung cancer screening exam. And so we update this document each year in our program. So we know that 79% of our patients are going to be a negative screen, Lung-RADS 1 or 2, and those patients just need to come back for their annual. And then about 16% of patients will need follow-up imaging, 3 or 6 month CT typically, and 5% of patients will need something more advanced, a PET or biopsy. So in summary, as I've said, lung cancer screening, I think it's a team effort. It's a program, not just a CT. And there is great opportunity for radiologists to be involved in lung cancer screening programs. We know the barriers are numerous, but we think that radiologists, and particularly our residents, that you all can find a great opportunity, I think, for getting involved in patient care and personal satisfaction in making a difference, particularly in this program. So thank you.